Hey everyone, welcome to Canadian Nurse Expert. Let's talk about one of the most important topics in cardiology, dysrhythmias. Recognizing and managing heart rhythm abnormalities is crucial for any healthcare professional. Welcome to our comprehensive dysrhythmia quiz. Today, we'll test your knowledge with 15 questions on cardiac rhythms and their management, complete with detailed rationales. Whether you're a medical student, resident, or seasoned clinician, this quiz will challenge your understanding and sharpen your ECG interpretation skills. Let's get started. Let's kick things off with atrial fibrillation, or AFib. What's the hallmark finding on an ECG? An irregularly irregular rhythm and no distinct P waves. The atria are quivering chaotically. This chaotic activity makes the rhythm irregular. You won't see organized P waves, instead you'll see a wavy baseline. Once you recognize it, AFib becomes clear. Now let's move on to another rhythm that has a very distinctive look on the ECG atrial flutter. This one is all about that classic sawtooth pattern. Imagine those triangular teeth one after the other. That's what atrial flutter looks like on an ECG. This pattern is created by the rapid, regular contractions of the atria. See, in atrial flutter, the electrical impulses travel around the atria in a circuit, causing them to contract much faster than usual. This rapid, organized atrial activity produces those characteristic sawtooth waves, also known as F waves, on the ECG. It's a dead giveaway for atrial flutter. Okay, time for a critical rhythm ventricular fibrillation, or VFib. This one is life-threatening and requires immediate action. Imagine this, you're in the ER and a patient goes into cardiac arrest. You look at the monitor and the rhythm is chaotic, completely disorganized. That's VFib. In VFib, the ventricles are basically quivering instead of contracting effectively, meaning the heart can't pump blood to the body. It's a dire situation. So, what's the first-line treatment? You guessed it, defibrillation. We need to deliver a shock to the heart to try and reset the electrical activity and restore a normal rhythm. Time is muscle, people. Now let's talk about a dysrhythmia that's often linked to an electrolyte imbalance, torsades de pointe. It's a mouthful, but it's important. Picture this. You see a rhythm on the ECG that looks like a twisting ribbon, with the QRS complexes varying in size and direction. That's torsades de pointe. This rhythm is often caused by a specific electrolyte imbalance, hypomagnesemia, or low magnesium levels. Magnesium plays a crucial role in maintaining normal heart rhythm, and when levels are low it can lead to this potentially fatal dysrhythmia. So, if we see torsades, checking magnesium levels is key. Let's dive into Mobitz type 1, or Wenkebach. It's about a progressively lengthening PR interval. The PR interval gets longer with each beat. Then, there's a dropped beat. The QRS complex is missing. That's classic Mobitz type Y. It occurs due to a conduction delay in the AV node. Let's talk about bradycardia, a condition where the heart rate is slower than normal. Think about it. A normal heart rate is typically between 60 and 100 beats per minute, but in bradycardia, that rate dips below 60. Now, not all bradycardia is bad. Some people, like athletes, naturally have lower resting heart rates. But when bradycardia causes symptoms like dizziness, fatigue, or shortness of breath, we need to intervene. So what's the treatment? We often start with atropine, a medication that can help speed up the heart rate. If that doesn't work, pacing might be necessary to maintain a normal heart rhythm. Alright, let's discuss ventricular tachycardia, or VT, a rhythm that originates in the ventricles and can be quite dangerous. Picture this. You're looking at an ECG and you see a series of wide QRS complexes, one after the other, with a rate typically above 100 beats per minute. That's VT. Now here's the key. VT is defined as 3 or more premature ventricular contractions, or PVCs, occurring in a row. These rapid heartbeats can prevent the heart from filling properly with blood, leading to decreased blood flow to the body. It's a serious situation that requires prompt treatment. Let's revisit atrial fibrillation, but this time we're talking about the unstable kind, the kind that requires immediate attention. Imagine this, a patient comes in with rapid atrial fibrillation and their blood pressure is dropping. They're confused, short of breath, and just not looking good. This is unstable atrial fibrillation and it's a medical emergency. The rapid, irregular heartbeats are compromising the heart's ability to pump effectively. So what do? We need to act fast and perform electrical cardioversion. This delivers a controlled electrical shock to the heart to try and restore a normal rhythm. Now let's shift gears and talk about a specific electrolyte imbalance that can have a dramatic impact on the ECG hyperkalemia, or high potassium levels. Think about it. Potassium is crucial for normal heart function, but too much of it can spell trouble. When potassium levels rise, one of the telltale signs on an ECG is the appearance of tall peaked T waves. These peaked T waves are a result of altered cardiac repolarization, the process of the heart's electrical system resetting after each beat. It's a clear indication that something's wrong with potassium levels. Let's explore junctional rhythm, a heart rhythm that originates in the AV node, that electrical gateway between the atria and the ventricles. Imagine this, you're analyzing an ECG and you notice something interesting. The P waves are absent, meaning the SA node, the heart's natural pacemaker, isn't initiating the heartbeat. Instead, the AV node is calling the shots. The heart rate in junctional rhythm is typically slower, falling between 40 and 60 beats per minute. And the QRS complexes, which represent ventricular depolarization, are usually narrow because the electrical impulse is traveling down the heart's normal conduction pathway. Let's circle back to ventricular fibrillation, or VFib, and talk about the most common cause of this life-threatening rhythm. Remember, VFib is characterized by chaotic electrical activity in the ventricles, leading to the heart's inability to pump blood effectively. And the most frequent culprit behind VFib is acute myocardial infarction, or a heart attack. When a heart attack occurs, blood flow to a portion of the heart muscle is blocked, causing damage and disrupting the heart's electrical system. This disruption can trigger VFib, making it a serious complication of heart attacks. Now let's discuss paroxysmal supraventricular tachycardia, or PSVT, a type of fast heart rhythm that starts and stops suddenly. Imagine this, a patient comes in with a racing heart, palpitations and dizziness. Their heart rate is through the roof, but then, just as suddenly as it started, it returns to normal. That's classic PSVT, and one of the go-to medications to terminate this rhythm is adenosine. Adenosine works by briefly blocking the electrical pathways in the heart that are responsible for the rapid heartbeat, essentially resetting the rhythm back to normal. It's like hitting the pause button on the heart's electrical system. Let's explore idioventricular rhythm, a heart rhythm that originates in the ventricles, the heart's lower chambers. Imagine this, you're looking at an ECG, and you notice that the heart rate is quite slow, typically between 20 and 40 beats per minute. The QRS complexes, which represent ventricular depolarization, are wide and bizarre-looking, indicating that the electrical impulse is not following the heart's normal conduction pathway. This is idioventricular rhythm, and it occurs when the SA node and the AV node, the heart's usual pacemakers, fail to initiate a heartbeat. The ventricles then take over as the pacemaker, but at a much slower rate. Let's unravel the mystery of Wolff-Parkinson-White (WPW) syndrome, a heart condition causing a fast heart rate. Imagine analyzing an ECG and seeing a slurring at the beginning of the QRS complex. This small wave, like a delta symbol, is the hallmark of WPW syndrome. It occurs due to an extra electrical pathway between the atria and ventricles. This accessory pathway bypasses the AV node, leading to pre-excitation and the delta wave. Let's wrap things up with one last review of atrial fibrillation, or AFib, the most common heart rhythm disorder. Remember, AFib is characterized by rapid, irregular electrical activity in the atria, the heart's upper chambers. This chaotic electrical activity leads to the hallmark ECG findings of an irregular rhythm and the absence of those distinct P waves. AFib can cause a range of symptoms, from palpitations and shortness of breath to fatigue and dizziness. Managing AFib often involves medications to control the heart rate and prevent blood clots, and in some cases procedures to restore a normal rhythm. That's it for our 15-question dysrhythmia quiz. How did you do? Did you ace it like a pro, or did some of those rhythms throw you off? Remember, mastering dysrhythmias takes time and practice, so if you stumbled on a few, don't sweat it. The key is to keep learning and reviewing those ECGs. Share your score in the comments below, and don't forget to like and subscribe for more educational content on dysrhythmias and ECG interpretation. See you next time.